Think we're good to start. Sorry, I have to click that. All right, welcome to Grand Rounds, the first Grand Rounds for the month of March. We'll start as usual with our land acknowledgement. So Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So I'm very excited today to introduce our Grand Round speaker, Dr. Amanda Yaworski. Dr. Yaworski is a pediatric neurologist who has a specialization in clinical neurophysiology and neuromuscular medicine here at CHEO, and she's an assistant professor in the Department of Pediatrics. She completed her clinical neurophysiology and pediatric neuromuscular fellowship at Stanford University after she completed her prior to that, she completed a pediatric neurology residency at the University of Alberta. And she's going to speak to us today about advancements in Duchenne muscular dystrophy and the impact on pediatrics. Welcome, Dr. Yaworski.
Thank you. All right. So yeah, as mentioned, I am new to CHEO. So if you guys see me wandering the halls looking lost, please do stop and say hello. I joined the neurology team just in the summer. And so I'm just going to be talking about some of the advances in our treating Duchenne and then how this is really pertinent to pediatrics as a whole. All right, so just some disclosures. I am going to be presenting some data on drugs that are both approved and not approved, and some of this is unpublished data that's been presented at seminars and things by the drug company. And I'm not a pediatrician, so also I'm going to try to make it relatable to a lot of other fields in general pediatrics. I know the medication obviously well in the field of neurology and neuromuscular, but not in general pediatrics. All right, so today we're going to go through the diagnosis of Duchenne and its classic presentation, as well as we're going to review current treatment and where the research trends are heading, and then how some of these medications in DMD have an impact on other disorders within pediatrics. So I think everyone here probably does know Duchenne muscular dystrophy quite well. It was first described by Dr. Bell in 1830 when he described his progressive muscle weakness in boys. Throughout the next few decades, there were really just single case series or sibling reports that were described by other physicians. So Dr. Conte and Gioja had described these cases, but never actually got recognition because at the time people thought they were just describing cases of tuberculosis. And then it was a little bit later that Dr. Marion was actually the first to suggest the inheritance was through females and that it really only affected males. It wasn't until the 1860s when Dr. Guillaume Duchenne kind of described what we classically know for DMD in his book titled Paraplegie hypertrophique de l'enfance de cause cerébrale. And Dr. Duchenne was actually one of the first doctors to ever obtain a muscle biopsy to look at under microscope, which really helped him with this, describing these patients. Later, maybe like a couple decades later, we found that there was really a lot of differences within the phenotype of this disorder. So a more milder phenotype was described by Dr. Peter Becker. And then it wasn't until 1986 when we finally found the gene for DMD on the X chromosome. And then the following year later found the dystrophin protein. So as mentioned, it's on the X chromosome where we find the DMD gene. It's quite common in my world. The incidence is about 1 in 3,500 to 6,000 live male births. And symptoms usually present in early childhood, so around 3 to 6 years. However, we can see symptoms much earlier, sometimes around 1 to 2 years old. Usually these are picked up in patients who have a family history, so either a sibling is affected or an uncle, and so they're usually brought to medical attention earlier. These patients will often have things like delayed walking or some subtle calf enlargement. But classically, patients will present with this proximal more so than distal limb weakness. They can have a waddling gait and a really exaggerated lumbar lordosis. And then they can have more subtle features with toe walking, decreased endurance, flat feet, and frequent falls. We all know well that as the disease progresses, it tends to involve many different organ systems. And so patients will often go on to have cardiomyopathy. They can have issues with growth velocity, even in steroid naive patients. So we know DMD does affect growth. There's respiratory issues, and then there is now quite well documented cognitive and behavioral disorders with higher rates of global developmental delays, autism, ADHD, and OCD. So this is just a depiction of a classic Gowers maneuver. So you can see here this boy is lying on his back. When asked to stand up quickly, he has to roll over onto his front. You can see he has this really wide base stance, pushes off the ground, and then eventually pushes off his legs in order to stand up. And so this is classic for Duchenne, really showing that proximal limb girdle weakness. So the dystrophin gene is really one of the largest in the human genome. So it encodes for 79 exons and approximately 2.5 million base pairs. And within this, there's many thousand different mutations that are recorded. Deletions account for about 2/3 of all of the cases. And there is this hotspot. So in between exon 45 to 53, there's upward reports of this affecting like 50% of patients with Duchenne having a mutation within this kind of hotspot region. And the thought for this region being such a hotspot is because the gene tends to undergo recombination within this region. And so looking at these exons is important because the reading frame rule is what dictates the phenotype and severity of our patients. So classically, the more mild Becker's phenotype results when the reading frame is not affected, while Duchenne, the more severe phenotype, results from an affected reading frame. So for example, when we're looking at this exon here, if a patient had a deletion of exon 48, the flat end of 47 is still able to match up to the flat end of 49. And therefore, the protein can still be read through, and you can still get a functioning protein, even though a portion of it will be deleted. In comparison, when we have exon 46 here that's missing, you can see the rounded end does not match up, to the flat end of exon 47. And therefore, the protein cannot be read through, and there's no functional dystrophin that's made. And so this is the difference usually between patients with Becker's and Duchenne. So as I mentioned, dystrophin is very large. It's part of this dystrophin glycoprotein complex. And its main role is to really stabilize the muscle membrane. And so this is really important because it helps us understand why muscle damage occurs in Duchenne. So if you're thinking about dystrophin, one analogy you can use is thinking about a trampoline. So when someone is bouncing, the muscle contracts and then relaxes. And the coil is what is analogous to dystrophin here. So the purpose is to make sure that muscles can move and withstand forces applied to them. But without dystrophin, the muscle cells lose their coil and no longer have the same strength or stability during muscle contraction. And as a result, they become further damaged with each use. Over time, the muscles stop being able to produce new cells, and the damaged muscles become replaced with scar tissue and fat, leading to fibrosis. The immune system also becomes quite activated with muscle damage, which in the short term is good. It helps repair muscle. However, when it's chronically activated, this can lead to chronic inflammation and buildup of scar tissue within the muscle. Finally, there's also damage to the outer protective layer of the muscle, which causes sodium, potassium, and calcium to leak through. And this can make it difficult to have the necessary power to cause an action potential and contract the muscle. So why do we care about this? All of this is important because it helps us with coming up with treatment. So unfortunately, the muscle injury that occurs in Duchenne is not straightforward, and therefore fixing one area of damage will really not be curative. But on the positive side of things, because there are so many different mechanisms of muscle damage, it really allows for more opportunity to go through and find different treatment options. And so we're going to be talking about which treatment options are targeted at what pathways today. So we know the main goal for treatment in Duchenne is really to maintain ambulation and strength for as long as possible by utilizing both medication as well as rehabilitation and non-pharmacologic measures. And I wanted to show this image because although I'll mostly be discussing the management from a neurological perspective, some of the most important care that patients with DMD receive is from non-neurologists. And so we know that managing the complications that are directly related to the disease, as well as those that are iatrogenic and caused by the medication we provide, is really important. So the orthopedics team is quite important for scoliosis and joint contracture management, the psychology for mental health and educational support, cardiology for the known cardiomyopathy, pulmonary for respiratory insufficiency, endocrinology for glucose and weight management, bone health and adrenal insufficiency, as well as physiatry for rehabilitation, and many others that I have not mentioned. So this just really further supports the need of multidisciplinary care for these patients, and understanding that what treatment we provide has many different effects on not just on the neurology side of things. So even before getting into the newer medical therapy for DMD, there has been a significant change in the natural history. So prior to any treatment, patients really rapidly progressed to loss of ambulation and would pass away generally by the second decade because of respiratory failure. 50 years ago, when the addition of spinal surgery and ventilation came, although loss of ambulation and feeding still occurred at the same time, patients were able to live into their 20s. And shortly thereafter, steroids began to be used with positive effect. So with the use of corticosteroids, we were able to essentially shift the regular trajectory back about 5 years, prolonging loss of milestones. And then, of course, with further cardiac management, we were able to even further prolong time to death. So with modern therapy, patients are living well into their 20s and sometimes longer. Because of this prolonged life expectancy, DMD is not really considered solely a pediatric disease. So this is a study that was done by one of our colleagues, Dr. Lockmuller, looking at life expectancy change since the addition of ventilatory care. And so you can see here that there's a 10-year difference in the median life expectancy when comparing studies of patients who used ventilatory support versus those that did not. So patients lived to a median of almost 30 years who used ventilation versus only living to a median of 19 years for those that didn't. So today, along with steroids, there are numerous other treatments that are being investigated that target the different aspects of the known pathophysiology behind Duchenne. And so in the basic sense, there are 5 main categories of therapeutic targets. Right now, treatment is really only targeted at single pathways, but the goal in the future is to be able to target multiple pathways to have the largest clinical impact for patients. So the steroids that we classically use work to decrease inflammation and fibrosis. And there's lots of ongoing research that looks at replacing dystrophin, which we're going to speak about today, which is where the majority of treatment really focuses. Now, in comparison to what I had shown for 20 to 30 years ago, where the mainstay of treatment was steroids, there are now numerous ongoing trials looking at ways to how we can treat the different underlying mechanisms behind Duchenne. So this slide was taken from the Parent Project Muscular Dystrophy website and was last modified in 2022. And even since then, there has been further changes and further improvements. So all of the medication here on the green bars are representing medications or trials that work to restore or replace the dystrophin through either exon skipping or gene therapy. The orange bars show studies that are attempting to reduce inflammation. So deflazacort is a well-known medication in this group, and then vamorolone is the new steroid that's being investigated. The light blue group looks to combat fibrosis, and the purple group looks to regulate calcium balance. The maroon group at targeting muscle growth and protection. The pink group looking at cell energy, and then the dark blue group at improving heart function. So as you can see, even within just one disease within neuromuscular, there's been a lot of ongoing really promising research. All right, so to start out, we're going to talk about the medication that works to decrease inflammation and fibrosis. So as mentioned, the main treatment in this category is the glucocorticoids. So I think most people here have probably used some form of glucocorticoid to treat patients for a whole variety of disorders. In Duchenne, the mechanism of action is not completely clear, but it's thought to be multifaceted. So there is known increase in myogenesis, muscle regeneration, and maturation, but the mainstay of treatment is really thought to be secondary to a reduction in inflammation. And the importance and utility of glucocorticoids is quite well established in Duchenne. However, the optimal administration regarding timing and side effects does still remain a debate. So we know that corticosteroids improve strength, they improve functional outcome, delay loss of ambulation, as well as cardiomyopathy, and they can reduce the need for scoliosis surgery. However, there are a lot of side effects, which is why there's often this debate on what is the best way to use steroids. So deflazacort has a lower lipid solubility, and it doesn't cross the blood-brain barrier as well as prednisone. And because of this, it's thought to have a slightly different side effect profile than prednisone. So deflazacort is thought to have less alteration in glucose metabolism, often leading to less weight gain, but it does have a higher frequency of cataracts and often is reported to have a worse impact on bone health and growth parameters. Similarly, corticosteroids are also thought to affect mood differently. So patients on deflazacort are more often reported as being more withdrawn, while those on prednisone are often more aggressive and irritated. Different regimens so far have shown similar efficacy. However, weekend dosing, instead of as opposed to daily dosing, have been found to have more improved metabolic and bone health measures. So this is often a strategy we'll use if we are required to start patients on steroids quite young. More recently, there has been some evidence to suggest that deflazacort may possibly be more effective at delaying disease progression. However, this is yet to be proven, and so far the efficacy remains the same. Vamorolone is that third steroid in that group, and so it's not currently approved in Canada, but many of you have likely seen patients on vamorolone because CHEO is part of the clinical trials for this. Vamorolone is the first in-class steroidal anti-inflammatory drug that differs from conventional glucocorticoids because it's lacking that 11-beta-hydroxyl carbonyl group. And so far the studies are showing that functional changes in time to stand or 10-meter walk remain comparable to prednisone, as you can see in these images here. So the orange bars are the natural history group, which is those treated by standard corticotherapy, and the blue group is the vamorolone treated patients. And you can see on their functional testing, their time to stand, time to run, they follow a very similar trajectory. However, what they found was different was the side effect profile. So patients in the prednisone group had a significant growth delay, which is a well-known side effect of corticosteroids, in comparison to vamorolone treated patients who really had more stable height percentages. And they found that there was minimal bone age delay relative to chronological age in vamorolone treated boys. Now, the one side effect so far that has found to be much more severe in the vamorolone group appears to be the risk of adrenal suppression, which does appear to be higher than those treated with prednisone. Excuse me. Okay. So we'll move on to the next group of our target medications here, which is replacing the dystrophin. As you can see, this has quite a lot of medication or research ongoing right now that works to either replace it through gene therapy or using exon skipping or stop codon read-through therapies. So about 10% of patients who are affected by DMD have a nonsense mutation when a stop codon is prematurely inserted in the mRNA. And when the mRNA is being translated, the premature stop codon prevents the DMD gene from being fully translated into dystrophin. Excuse me. Now, aminoglycoside antibiotics such as gentamicin bind to ribosomes and allow them to read through premature stop codons during translation. And they allow ribosomes to insert alternative amino acids at the location of the mutant stop codon. So therefore, it can be read through and create full-length dystrophin. However, as we know, aminoglycosides have a lot of side effects. So it was just based off this mechanism that they created a medication called Adalarin. And so Adalarin is an oral agent that suppresses these nonsense mutations in a similar way to aminoglycosides. So Adalarin is not currently approved in Canada or the US. It has previously been approved in Europe. However, there are ongoing discussions as to whether they will continue to approve it, and we'll speak a little bit about that. So, although it's been shown to have improvements compared to placebo with performing certain tasks, so the ability to climb stairs, get out of a chair, walk short distances, it did not meet its primary endpoint, which was a change in the 6-meter walk time. And so this is why there's been new discussion whether it should continue to have approval in Europe. So what you can see here is in this picture in A, when looking at all patients, there was no change in 6-meter walk time between patients treated with Adalarin and versus those with placebo. However, if you break it down into their baseline 6-meter walk time, they did found that patients who had a baseline between 300 and 400 meters, there was a significant difference in the Adalarin versus placebo group. And so it was hypothesized that this group showed this expected change because the 6-meter walk time was more sensitive in this group because these patients were really on that borderline of ambulatory deterioration. So because of these mixed studies, the pharmaceutical group went to real world data to see what they could find. So they have this STRIDE registry, which is real world data patients who have been treated with Adalarin between 2015 and 2022. On average, most patients were treated for 5.5 years. And they compared it to patients who were on the INRG DHNF database, so those not treated with Adalarin between 2006 and 2016. And what they found is that patients who were treated with Adalarin lost the ability to walk 3.5 years later than those not treated. And however, there were some limitations to this. So as you can see, the STRIDE registry is much newer. It's about 10 years newer than the compared registry. And so the thought was that the improvement in loss of ambulation could not be accounted for solely by Adalarin because, in these 10 years, there's been new pharmacological as well as non-pharmacological advancements. So Adalarin couldn't be the sole reason for these improvements. Now, Adalarin has been used previously as well in patients with cystic fibrosis. So for those who have cystic fibrosis caused by missense mutation. So in animal studies, there was good evidence that Adalarin allowed read-through of these premature stop codons and synthesis of full-strength protein. However, in human models, the initial results were negative, but the speculation was that this was actually secondary to interference by aminoglycosides. So as you can see in this image, when they had broken it down to patients who had been taking tobramycin versus not taking tobramycin, they found that those who are not on those antibiotics did show a change in their FEV1. However, because of this, they conducted a new study on patients who were not on any aminoglycosides. And unfortunately, they did not find that patients taking Adalarin had any improvement in clinical outcome, including quality of life, lung function, decrease in exacerbation, sweat chloride, or weight compared to those on placebo. And they also found, unfortunately, that patients had higher risk of kidney damage on Adalarin. So from my knowledge, this is not utilized at all in cystic fibrosis anymore. Okay, we'll go on to the next category within replacement of dystrophin, which is exon skipping therapies. And so, as mentioned earlier, there's this hotspot for gene deletion, hence this is where exon skipping therapy has focused. These 4 medications listed here are approved in the US, but are not approved in Canada, and we'll talk a little bit about why that is. So all of the exon skipping therapy that is approved in the US uses a PMO-based antisense oligonucleotide. And so when the body needs to make a protein, information on the DNA on how to produce a protein is passed into the cell through messenger mRNA. And PMOs are essentially a synthetic molecule modeled after the natural framework of RNA. PMOs bind to specific pre-messenger mRNA, and then they use this antisense oligonucleotide to do the exon skipping. So in normal dystrophin, mRNA, all of the exons fit together, the ribosome is able to read through and normal dystrophin protein is produced. However, in the case of Duchenne muscular dystrophy, in which there is a deletion of exon 53 to 55, the ribosome is not able to read through and therefore either unstable or no dystrophin is produced. Exon 52 would have to be skipped essentially in order to restore this disrupted reading frame, but it creates this internally deleted but largely functional dystrophin protein. And so this is thought to convert that severe DMD into a more mild BMD phenotype. So far, published data on the exon skipping that uses the standard PMO therapy has found that it does increase the rate of dystrophin found in muscle. So in normal boys who have DMD, there's essentially no dystrophin in the muscle. And using these therapies have been able to increase the dystrophin up to about 1 or 2%, depending on which therapy is used. And it also does increase the rate of exon skipping. And so because of this, they have found some functional improvements with a decrease in the decline of the FVC rate as well as the 6-meter walk time. However, unfortunately, because of the PMO backbone, they have found that there's issue with penetration into the different muscle types. So there's no effect on the cardiac muscle. And these do need to be given via weekly IV infusion. So it can be quite cumbersome for some patients. So what do we make of this really? The clinical significance of these reports really, the amount of dystrophin is what remains unknown. So we know that in patients with DMD and BMD, dystrophin levels at times have been shown to partially correlate with the clinical severity, but not always. There's some reports that that milder phenotype can be associated with dystrophin levels as low as 3%. So that could possibly be achieved with the exon skipping therapy I just reviewed. And even in recent studies of muscle biopsies from patients with Becker's, Duchenne and healthy controls, they found that modestly higher dystrophin levels, so anywhere between 2 and 7%, were associated with this better outcome. So this, study questions maybe that is enough dystrophin. However, other studies have really found more conflicting results. So this study looked at adult patients with Becker's muscular dystrophy, and they found dystrophin levels ranged anywhere from 4 to 71%. And they did not find that there was any correlation between the percentage of dystrophin expression and the MBIC sum score. However, what they did find is that all patients with less than 10% dystrophin had that more severe phenotype. So they hypothesized that dystrophin amount did not correlate with phenotype unless it was below 10%, and then that would still be quite severe. So this study, hypothesizes that exon skipping therapy would really not be enough. So for these reasons, these are one of the main reasons that it hasn't been approved yet in Canada. So because of this issue with penetration into the different cell types, as well as the small amount of dystrophin that has been created, pharmaceutical companies have been working on methods to enhance their antisense oligonucleotide exon skipping therapies. So these are all just different methods that different pharmaceutical companies have used. So one way is through adding a peptide onto the standard PMO, which is designed specifically to help with tissue penetration, and in animal models has showed good penetration in both skeletal and cardiac muscle. And so far in human studies, they have found that there is a significant increase in dystrophin, so some reporting up to 5% in muscle and a higher rate of exon skipping compared to classic PMO. Similarly, other targeted approaches is through antigen binding fragment, which targets this transferrin receptor, which is specifically expressed in muscle cells. And this is also thought to significantly increase the amount of dystrophin compared to that's seen on those naked oligonucleotides. So these have, really exciting data, and I think we'll soon see the results as we start to participate in clinical trials using these more enhanced exon skipping methods. Now, exon skipping has been used in other fields, even outside of neurology. So all of this is in animal models. Most of the data you can see is in something called Usher syndrome, which is a disorder causing retinal degeneration. Spinal muscular atrophy is a classic one that we know, which uses a similar, it usually is an antisense oligonucleotide, but it promotes with exon inclusion. And then there are animal studies looking at Huntington's and Joubert syndrome as well. One of the most interesting ones I came across was actually looking at treating anaphylaxis with exon skipping. So what researchers have found here is that there's this KIT receptor, which is a receptor of tyrosine kinase found on mast cells, whose gain of function mutation can lead to systemic mastocytosis. And what they found was in giving mice this exon skipping ASO, it resulted in integration of premature stop codon within the mRNA, and this actually led to lower mast cell numbers in the skin and the peritoneum. So exciting area of research, and we'll see what comes when they move to adults, or humans, I should say. The last category within the dystrophin replacement is gene therapy. So the goal of gene therapy is really to introduce DNA instructions into cells within the body. There's different types of gene therapy. There's those that are targeted at replacing dysfunctional gene with a functional copy. There's those targeted at correcting the disease-causing variant in the gene, and then those targeted at introducing a new or a modified gene to help treat the disease. And so there's three main components that are important for delivering gene therapy. There's the transgene, which is the genetic material that's being delivered, the vector, which carries the transgene into cells, and usually this is through an inactive virus that will not cause an infection in patients. And then finally, there's the promoter, which is what turns the transgene on. So an example with this would be a functioning copy of the dystrophin gene is the transgene that's carried by an adeno-associated virus, which is the vector, and then turned on by muscle or heart-specific promoters. Now, there's lots of limitations to gene therapy. It's unclear how long benefits will last, and this likely will vary on an individual basis. The effectiveness also varies depending on the age of the patient and the disease stage. And so far, we know that we cannot redose patients because their body will produce antibodies after the initial delivery. There are some serious immune responses that are possible. And of course, it's a very expensive treatment. So there is still lots to learn about this. Some of the first delivered AAV gene therapies actually occurred in the late 90s in patients with cystic fibrosis. Who received this AAV CFTR through the maxillary sinuses. And then I believe the first viral gene therapy approved was for Leber's congenital amaurosis, which is a heritable retinal dystrophy. And so both the case of the cystic fibrosis and the Leber's, the gene therapy was provided locally. So for the patients with cystic fibrosis, it was injected directly into the maxillary sinuses. And for the patients with Leber's, it was injected underneath the retina. And so it wasn't until the early 2000s that they found that single IV delivery of AAV9 could result in actually whole body muscle transduction in mammals. And this really expanded the options or possibilities for gene therapy. SMA, the treatment of SMA, the on-symptom ipoparbovec, is probably the most well-known gene therapy, which is a single IV dose by AAV9, and for treating SMA so far, that has worked quite well. Now, as I mentioned, these are very expensive gene therapies. So Hemigenex, which is an American drug, and Vecvis, it was just approved in Canada, and these are topping at the most expensive drug in the world. So these are one-time viral vector therapies used for hemophilia B, and those cost around $3.5 million per use. Skysona is next up on the list, which is to treat cerebral adrenoleukodystrophy. Again, I believe only approved in the US, coming in at 3 million. And then Zynteglo, which is to treat beta thalassemia. Again, only approved in the US, is 2.8 million. When we look at what is approved in Canada, in terms of cost, Zolgensma, or that the gene therapy for SMA, is right up there. It's listed as 3 million here. I think some numbers report it's more 2.5 million, but regardless, still very expensive. And then you can see the others on the list are mostly enzyme replacements for ongoing therapy, so ASO therapy, which is really required lifelong. Now, when we look specifically at gene therapy for Duchenne, as I mentioned, the dystrophin gene is very large, and so it's too large to actually be able to fit into a viral vector. So the main idea for microdystrophin was actually found in the 1990s after researchers found a patient with a large central deletion of dystrophin who remained ambulant still at 61. And the deletion was so large that it actually accounted for 46% of the dystrophin, essentially cutting the size of the gene in half. Another patient was found shortly thereafter who was missing almost 50% of his dystrophin as well, and he remained being very active. He was a bodybuilder still at 25 years of age. So because of these discoveries, researchers realized that some portions or exons of the dystrophin gene are more important than others. And so people were able to design these mini or microdystrophins that use this functional but shortened dystrophin that is seen in some patients with Becker muscular dystrophy. So far, there is no approved gene therapy in Canada. There is one approved gene therapy in the US, and this was approved on accelerated approval because of the amount of dystrophin expression found in the muscle, which is sometimes reported up around 50%. Although there is very, very significant variability in this. In terms of functional scores, the EMBARK study is ongoing. And so recently the drug company presented some data that unfortunately it did not meet its primary endpoint, which was to look at NSAA scores compared to placebo, which is just a functional measure of testing strength. But what they did find was that there was still improvement in time to rise from the floor and time to 10-meter walk. There are many different clinical trials. You may see some patients treated at CHEO who are also undergoing gene therapy through different companies for DMD. Really briefly, I just wanted to touch on CRISPR technology, which uses DNA sequences from bacteria and this CRISPR-associated enzyme to really edit the patient's genome. So as opposed to just replacing a gene, which is what the previously discussed gene therapy does, CRISPR is meant to provide tools for ongoing editing of genes. Currently, most CRISPR studies are all preclinical. However, there is some unpublished data of showing improvements in hematology patients. So these hematology patients have disorders of beta thalassemia or sickle cell. And so what they did was the CRISPR technology was meant to deliver a gene that boosts the production of that healthy fetal hemoglobin that's usually turned off shortly after birth. And in the patients that were treated, there was 15 who were treated with beta thalassemia and 7 with severe sickle cell disease. So far, all of the patients have shown improved hemoglobin levels and a decrease in the amount of transfusions that have been provided. So I just wanted to include this because CRISPR is something that is a very hot topic and will likely be used in many different diseases within pediatrics in the next decades to come, but there is still a lot to learn from this. Okay, the final group of disorders I'm going to be discussing today is treatment for Duchenne that increases muscle mass and regeneration. So one of the medication called givinostat is an HDAC inhibitor. And so HDAC inhibitors have been used predominantly actually in polycythemia vera and myeloproliferative neoplasms. And it works for polycythemia vera because this causes excessive proliferation of bone marrow components, which are thought to be due to these JAK2 mutations. And so givinostat really targets cell growth and reduces proliferation of hematopoietic cells because of its target on the JAK2 mutation. And so as you can see in this image here, this is patients who have polycythemia vera. And all of the green bars are patients who have had at least a partial response to givinostat, whereas the red or the blue bars are patients who did not respond or withdrew from the study. So you can see like upwards of 80 to 90% of patients have shown some response to this. Now in Duchenne, it has a different mechanism of action. So as I previously discussed, there is decreased regenerative capacity of muscles in Duchenne muscular dystrophy. There's continuous muscle damage through contraction, which causes this influx of calcium, and then this activates these calcium-dependent proteases to further degrade muscle membranes, as well as there being loss of nitric oxide, causing increased oxidative stress and HDAC activity. And therefore, the thought is by inhibiting HDAC, you actually increase the ability for muscle regeneration. And so far, again, this is data that was actually presented yesterday at one of the MDA conferences. The EPIDIT study has so far shown that boys who are treated with givinostat compared to placebo have shown a slower decline in their ability to climb 4 stairs. And so again, this is still under clinical trials, but so far there's been some promising data here. The last group of medications which works on this increasing muscle regeneration are anti-myostatin medications. So myostatin was first found in the late 90s, in 1997, in myostatin knockout mice who had increased muscle mass. And similar mutations have been found in certain animal populations, so certain cattle or those whippet racing dogs who are very, very muscular. So you can see this dog here was found to have a mutation in the myostatin gene, causing an even higher amount of muscle than normal. And so in 2004, this was actually confirmed in humans. So it's a really interesting story. What happened was there was this healthy former professional athlete who gave birth to a child, and after the child was born, this baby was noted to be very, very muscular. So you can see in this image, at birth, there was already really protruding like quadricep muscles and gastrocnemius muscles. And eventually this child was found to have a loss of function mutation in the myostatin gene, as well as with the mother was later to found this. As people looked more into the myostatin gene on the opposite end of the spectrum, myostatin has been found to be elevated in cachectic patients as well as those with HIV when compared to healthy controls. So the thought is that myostatin loss of function did not appear to have negative impact on patients. So this is where they started looking into this for whether this could be a negative regulator of muscle growth, and if by inhibiting this, they could actually increase the muscle regeneration. There are many clinical trials ongoing, as you can see, for many different neuromuscular disorders, as well as even non-neuromuscular disorders. There's look at patients with COPD, oncology patients who are quite cachectic, but unfortunately, so far, it has really been quite promising in animal models, but so far, the human data has not been as exciting, but we're looking forward to seeing more formal results as these studies get published. All right, so to conclude, there's many different targets for treatment, primarily through dystrophin replacement. That's your exon skipping and your gene therapy, but as well as inflammation, fibrosis, and muscle regeneration. We still have a lot to learn, both from DMD patients and non-DMD patients who many of these treatments have similar or slightly different mechanism of action, so can be used for many different disorders. And the management of DMD is completely different than it was 20 years ago. So this is both exciting and also encouraging. It makes it a lot easier having these discussions with patients, just being able to discuss all of the promising research that really is on the horizon. All right, so thank you. I'm happy to take any questions.
Amazing. Thank you, Amanda, for that excellent review. I had no idea there was so much similarity between, or close between hematology and neurology that has
Yeah.
come to light. That was super interesting and really highlights so much work being done in this field. So thank you for that review. And are there any people that have any questions for Amanda? It was so thorough. There's no questions. I guess I'll start with, I'm like trying to think, because I was so caught by the hematology not analogies, similarities. I guess I have a question about the steroids, and I can see Leanne's Ward's picture there. And so we use steroids a lot in oncology, as you know, and I'm just wondering why. So the side effects, the adrenal suppression that you don't see with one versus the other, and is there a reason for that? We see it a lot with, well, we use in oncology, prednisone and dexamethasone are the two mainstays. And we see a fair bit of it, like a lot of adrenal suppression, almost all of them who are on it for even a month, and where patients are on it for a super long time. So I'm just wondering if there's anything there. And
so there's definitely there's definitely adrenal suppression in all of the steroids. So in the ones we use, the prednisone, deflazacort, and then more recently the vamorolone. And actually was really interesting in the vamorolone trial, they found that even non-treated DMD patients also had adrenal suppression. So that also kind of confounds the picture a little bit, that perhaps DMD patients, their adrenals aren't working great. I don't know why some are more severe than others, but we do see, as I mentioned, that the vamorolone group are a lot more severe. I see Dr. Ward wants to comment. Yeah, go ahead.
Yeah, thank you for that. Just a couple comments. Great talk, Amanda. That was a really nice walkthrough, and I thought you did a super job of really breaking down the pathophysiology and the treatment targets for us. So thanks for that. In terms of the adrenal suppression, it's really interesting. We're working on a paper right now with Alex Ahmet, and the issue that readers need to understand, and this will come out in a paper we're working on now, is that the pivotal vamorolone trials used an assay for which the 500 nanomole per liter cortisol threshold is too high. So 500 nanomole per liter on the ACTH stim test was used to define whether there was adrenal suppression or not. But that's a threshold that's based on the first generation cortisol assay. For the studies, actually a second generation monoclonal assay was used, and the more appropriate threshold is actually around 400 or so. And so when we reanalyzed the data using a threshold on ACTH stim tests of 400, that 20% of boys who failed according to the 500 threshold did not fail. So we're not as convinced that there's innate adrenal suppression as perhaps we once were. And also, overall, that's just a more appropriate threshold. Now, we still did see, though, that vamorolone, it causes more adrenal suppression than prednisone, even when that threshold was lowered.
Oh, that's interesting. Thank you for sharing that.
Sorry, Leanne also had a question in the chat, which we'll do before going to Dr. Lockmiller. So did you answer it with that? Do you think steroids are here to stay? And what do you think the very high doses of gene therapy?
Yeah, I think at this time, definitely steroids are here to stay, possibly not in the young patient. In the states where there's more approved therapy, a lot of people are erring on the side of treating with exon skipping therapy, or even gene therapy prior to doing steroids, so just prolonging it. But I do think for now it is still one of our standard of cares, and something that will be here to stay. And then you had a question about the very high doses of gene therapy. Do you mean the high doses of steroid, or the actual viral vector gene therapy that's provided?
Oh, yeah, I mistyped. Yeah, the very high doses of steroid therapy in the gene therapy context, because we're seeing osteoporosis. You can have vertebral fractures within a few weeks or even days of high dose steroid therapy. And I don't see that the companies are really thinking about bone protection in the context of these very high doses, as well as adrenal insufficiency preventative home management. So it worries me that the high dose steroids will offset the benefits of the gene therapy?
Yeah, I think the gene therapy in Duchenne is very complicated. It's not as simple as, I shouldn't say simple, but if you think about our gene therapy for SMA, it's a little bit more straightforward. So we do see so many side effects happening with this, and it's not straightforward. And unfortunately, I think the really high doses of steroids are required to prevent some of those really life-threatening side effects that we can see with the gene therapy. So I think it's, the better of two evils. I think it's something that unfortunately is needed, but you're right. I think there does need to be a lot more attention paid to how we can prevent this bone health, because if a patient gets gene therapy, they're doing great, but they fracture their femur, like that's going to significantly impact their walking rate. And so the functional outcomes may be really, really affected by that.
Thank you.
Thanks. Dr. Lochmiller?
Thanks. Great talk, Amanda. Thanks so much. Very good overview of everything that's happening. And as you pointed out, it's getting more complicated, but it's also, I would say, getting more exciting, because I think we are almost at a stage where we can offer every child with Duchenne to enroll in some kind of research, whether this is a very advanced gene therapy or exon skipping or something more with an oral therapy, whether it's vamorolone or givinostat. So this is great, and whether all of them will be part of our future armamentarium is unclear, but we'll find out. I guess one of the concerns is, and maybe you also have some thoughts about this. You mentioned that lots of the new drugs, especially the very expensive ones, are approved in the US, and then sometimes they make it to Canada a couple of years later, but they don't always do. So for instance, the first generation exon skipper, so they were approved more than 5 years ago in the US, and they're still not available in Canada, which obviously leads to frustration by families. So what are your thoughts about that? Is there a possibility that this changes in the future with maybe more effective therapies, and these first-line therapies were just not good enough?
Yeah, I think that's, as you mentioned, it's so hard. I've had patients actually ask me, like, should I move to the States, right? Because you're right, there's so many more treatments approved there. I think especially when it comes to those exon skipping therapies, the data is just not robust enough to really be approved in Canada. So of course our patients are missing out on these, but I think we have enough clinical trials ongoing and other options for more of these improved, right, these enhanced PMO exon skipping therapies. So I don't have a good answer for that. It is hard for patients when they can't have access to this, but there's so many other hopefully more promising options that are coming that the patients can participate in clinical trials. So I think that's probably the big reason why it hasn't been approved in Canada and likely won't, like as we saw with Adalurin, which was only approved in Europe. Now they're talking about pulling back. So it does add a little bit of an extra layer to things when you have a public healthcare system and it's not these private insurance paying for it. There's a little bit more due diligence, I think, that needs to go into which drugs are approved.
On that note, Amanda, what is the availability of patients in Canada having access to these trials? Are they across Canada, or do they have to travel, or what? Can you comment on that?
Yeah, for sure. So at CHEO, like we're so fortunate. We have such a good team with Dr. Lochmiller and Dr. McMillan that we have a lot of available trials here at CHEO. And then across Canada, oftentimes the drug companies will try and include kind of broad coverage. So they'll have, like, often Ottawa or companies sites in Ontario will see patients from Quebec and in the Maritimes, and then out west there's often sites. So we do have a lot of patients that travel to CHEO from Quebec and the Maritimes to participate in trials, and then likewise patients can travel across Canada if there are trials that aren't available in Ontario. But I would say within Ontario, really, we have access to quite a lot of the trials, so most patients are able to stay there.
Great. All right, I don't see any other questions. Oh, yes, Dr. McMillan, excellent. I'll read it. So, excellent presentation. Do you have an opinion as to which of the two classes of treatments may offer promise regarding functional improvement in DMD patients? The new protein conjugated ASOs versus mini microdystrophin gene replacement therapies?
Yeah, that's a good question. My personal opinion is probably actually there's a little bit more functional improvement in some of these new like beefed up these protein conjugated ASOs. I think the mini microdystrophin, the results have been so variable, where some patients it works very well and other patients it does not work as well. So my opinion is that these newer protein conjugated ASOs will actually have more robust results, but that's just my opinion. But we'll have to see as more data comes.
Great. Thank you. And then Dr. Berman is asking if you could speak to how advanced imaging modalities may help direct therapeutic strategies in DMD.
Oh, sure. Yeah. So I think there's lots and lots of ongoing research in different imaging modalities within Duchenne and other neuromuscular disorders. What's exciting about imaging modalities is it's a great way of picking up disease progression or improvement. So unfortunately, a lot of our studies are limited to functional data, which is very important. That's what matters to patients. You know, they care, am I able to go upstairs easier than not? But there's a lot of limitations with that. You know, most recently we were part of this FSHD working group, and they found that even though patients feel they're getting better, on imaging studies it actually shows that they're worsening. So I think these imaging studies can really pick up more minute changes within the muscle itself and can help guide treatment that way.
Awesome. All right. Well, thank you, Amanda. That was a really amazing, amazing review of Duchenne muscular dystrophy, and really highlighted all the work that's been done by lots of people at CHEO and internationally. So thank you so much for such a really great rounds.
Yeah, you're welcome. Thanks, everyone.